we did work together on the McNair grant, and then tomorrow there will be the presentation as well on encouraging people to apply for a grant, and we had a lot of fun doing it this summer. We've also talked a lot about end-of-life care and decision-making issues for families as well as the patients themselves in the course of this project and in the course of some of the work we want to do. We haven't been able to work together on that subject yet. But we're going to talk today about the importance of language in terms of how we talk about end-of-life care and the importance of social connections and communication both with families and with the patients themselves in terms of how doctors and nurses relate to them. So we're going to start with the clicker you have.
See if it works. Is it working?
Screen. This is
not working.
Is it working?
Well, yeah.
That's what's working.
Oh yeah, okay.
Your main responses. So yes, if your family member was hospitalized and you were being told there was no hope, what choice would you pick for their last week of life? Do not resuscitate, comfort measures only, intubate, and allow natural death. So go ahead and make your selection now, as they like to say, the faculty meetings. How does it show up?
Put to the
Okay.
yeah, comfort measures on.
All right. So half of you chose comfort measures only. No one chose it, do not intubate, and then a quarter each for do not resuscitate and allow natural death. Why would you say that was the common, that this was the pattern that came up in this room?
The word comfort.
Right.
Sorry?
Seems the most humane thing to do.
Okay. Humanity, comfort.
The word comfort.
The word comfort. What else?
I didn't know what intubate.
That makes it kind of funny, but it is also true, and it is one of those things that I found in terms of the next aspect of this is in teaching this class. I teach the death and dying in social context class. I taught it last spring. I'm teaching it this upcoming spring. And part of it is, what is your audience familiar with? Right? So in talking to Francis Marion students, in teaching this class, I have traditional students as well as non-traditional students, all of whom have some relationship with death in terms of maybe having a family member who died or a distant family member, but not necessarily understanding all the issues that relate to end-of-life care. And so some of it is setting up what is end-of-life care and what are the issues that surround that. So, do not intubate really is referring to whether or not someone wants a feeding tube placed, whether or not they want
A ventilator.
a ventilator, excuse me, that was the word, a ventilator. Do not resuscitate, obviously, the code blue kind of thing that goes on in terms of making sure that someone, if their heart stops, that they get resuscitated. And oftentimes you watch any of the hospital shows, that sort of thing, they have those moments where somebody's going in a code blue and then come and they try to give the person CPR and then someone else in the scene says, oh, wait a minute, no, they have a do not resuscitate order. So they're doing more and more in recent years to make that very evident to anyone when someone does code in their room, as they would call it. If someone does have a heart attack and is no longer living with a heartbeat going, that they have some evidence clearly in the room that the person has a do not resuscitate order. Oftentimes it also involves conversations with the family about their wishes for that person, and especially in those cases where the patient cannot speak for themselves.
So those are mutually exclusive, are they?
No.
If they don't seem to be.
No.
I'm sorry, I didn't.
No, they're not mutually exclusive.
Oh.
And we'll go on a little bit later. We'll start talking about the current terminology that's out there right now and what people are using.
All right. So why? Well, not only do individuals differ in their attitudes towards and feelings toward death, but it depends sometimes on the situation. And the same person may actually differ in those ideas from situation to situation. So we started parsing that question out, rather than it being so general. We started parsing that question out in terms of what would you want to do in a situation where you had been in a near-death car accident and there was no hope for you to recover. What would you want your family members to do? Compared to you're at the end of life and there's no, you've lived a long, healthy life for 75 years and now you're at a point
75.
Sorry, we got to know now. We got to resuscitate order. Sorry, I was going, as a sociologist and a scientist, I was going based on the average life expectancy right now. 78. So, okay.
See, language is very important.
Yes. So 95 at the end of life, if that's something you want to have someone, whether or not you'd want your family member to be intubated, whether or not you'd want them to be resuscitated, whether or not they'd want to be kept alive on machines, really. And so what we mean by being dead or being near death ends up being different in how we communicate those ideas is very important in terms of how we communicate with the doctor, with the nurses, with family members, and with anyone else involved. And I've found that with teaching the class to the students, a lot of those conversations have never been had with family members in terms of what one's own wishes are, but then also what one's parents' wishes may be or their grandparents' wishes. So we're not familiar with what would happen if a sudden event happened and one was not able to speak for oneself in terms of a final decision. So it's important to talk about it in terms of how we communicate and what each person thinks about when they think about being near death or being in a situation where they can't make their wishes known. In our culture, we have a higher tendency to talk about it in terms of someone slipping away rather than the actual event itself. Most Americans actually slip away or die by slipping away alone. And why is this so? Well, there's a number of possible reasons. One, the medical advances have made it so that we tend to keep one's body alive beyond what we would allow in terms of allowing natural death. Right? We keep people so that they can survive longer with terminal illnesses. We keep them so that the body continues to operate even if one is not able to speak for themselves or communicate with their family in any way. Physicians may want to avoid those situations because they tend to see the death of a patient as maybe their own failure, so they might avoid interacting with a patient. And when I'm thinking of those are situations where someone has been in a hospital room for months without responding, sometimes years, and the physician may feel like there is nothing that they can do to help this person beyond the condition that they're currently in. Other things, dementias then often take away the awareness of the patient themselves as they're slipping away. And then we have a lot of pre-terminal and terminal sedation that occurs in terms of helping someone not have to deal with the pain in those last few days. And then there's just simply not enough staff to see patients and not enough family members. I'm sure we've all had students who've contacted us and say, my mother's really sick in the hospital, someone's got to sit with her, someone's got to be there with her, my dad has to work, my brother or sister's also got to go to school. So then they contact us and let us know that they've got to be there to spend some time with their loved one in their last moments or just in terms of helping them deal with an illness. We've gotten to a point in our society where death has been medicalized. What we use in sociology is medicalization, where it's become increasingly under the surveillance of the bureaucratic hospital medical complex, so that most people, more people than in other cases, I guess I would say majority of people, end up dying in a hospital rather than at home. And that's in part because of how the system has been set up. In the top graph, you can see that the older model is a transition model where the goal is that someone receive treatment and aggressive medical care until the point at which they are no longer able to see any recovery or any additional curative treatment. And so then they might get involved in hospice care. Hospice care is established when someone has an estimated 6 months or less to live. Whereas the newer model, in terms of talking about hospice care and palliative care, you might spend some time trying to find a curative model, curative treatment for someone, but also being able to manage their symptoms. If it is pain symptoms, then doing something to manage those symptoms. And then extending that, not till just the point of death, but also recognizing that the bereavement period for the family deserves some time and attention from a practitioner's perspective as well as from a sociological perspective. And it's also recognizing, in terms of coping, that there are 4 challenges for someone who is dying. There's the physical challenges, the psychological challenges, and this is one that I think has grown in importance in what we're talking about as well, the sense of being in control of one's dying process and their last days or their 6 months, however long they've been given, and then attachment to their family and individuals, and the spiritual means. The spiritual challenges are also a part of that. So hospice care, and I'm sort of presenting this as I presented over the course of the semester to students so that people get familiar with all the language and all the ideas that we're talking about here. Hospice care is designed to give support to people in the final phase of a terminal illness, so it focuses on comfort and quality of life rather than curative treatments. It arose from a desire to provide what we think of as humane or compassionate care to patients we knew were terminally ill. The incidence of cancer, terminal cancer, have risen over the last 15, 20, 30 years, and so as that's increased, then we know that there have to be more opportunities to provide compassionate care when someone has been diagnosed as having a terminal illness. Medicare and insurance companies have specified that hospice care can be applied and can be paid for, but only when someone has been diagnosed as having 6 months or less to live and is no longer willing to pursue curative treatment. So those are the rules in terms of paying for it. Many hospice care programs are now home-based, and it's important in terms of how we look at it as a multidisciplinary approach. So we get doctors, nurses, social workers, and all the religious congregational leaders, the volunteers, and the physical and occupational therapists. Because even if someone is at the end of life, they may need physical and occupational therapy in particular in terms of being able to keep their body movements and be sure also in terms of the care that they would receive from a nurse, in terms of being in a bed and not developing things like bed sores. Palliative care, the difference really is the fact that it's applicable to any patient with a chronic or terminal illness. It's not specific just to those who have been diagnosed with less than 6 months. And one can receive both palliative care treatments and curative treatments simultaneously. Both of them have become specialties in the hospital and in medical schools as well, palliative care and hospice care. The goals: to focus on reducing and alleviating problems related to illness, symptoms, and pain. Supporting the rights of patients to keep control, and I think this gets into what Ruth's going to talk a lot more. Keeping control over those healthcare and end-of-life care decisions. This is based on the Patient Self-Determination Act. It was enacted in 1991 and is responsible for making sure that patients have the right to participate in and direct their own healthcare decisions, and then also in terms of their rights to decide on surgical treatments and refuse surgical treatments and medical treatment, and their rights to prepare an advance directive, and then the information that they need in terms of utilization of these rights. So, to be more clear, in terms of what an advance directive is, and a lot of times people think it's only about having a living will. Advanced directives often go into more than that. There's several categories like we just talked about. They are instructions to be taken, for actions to be taken in the future, if certain events that occur, and we are unable to speak for ourselves at the time. Did anybody see The Descendants? The movie with George Clooney? Right? The basis of that movie, even though the trailer gives us this idea it's a comedy, the whole basis of the movie is this idea that his wife was injured in a boating accident. She is now no longer able to speak for herself. She's in a coma. And it's all about how his family responds to that. And he goes and he talks to her parents about the advanced directives that they each have and the fact that she's going to be removed from the machines after, I think it is 30 days of no response to treatment. Well, that's because they had an advanced directive. Living wills give limited effectiveness. There have to be maybe more specific measures identified in an advanced directive. So that's why maybe do not intubate is used, because saying I don't want to be kept alive on machines is insufficient to say, because then the doctors and nurses have to say which machines, which ones are acceptable and which ones aren't. So the physicians would have trouble responding to that. And then it doesn't come to the attention of the healthcare provider unless unless the person's physician or maybe their family comes to the doctor who's treating them and says they have an advanced directive in place. They are actually legal in every state, thanks to that PSDA Act passed in 1991. And patients can change. So a lot of people aren't aware. The patients can change the wording of the forms. A lawyer is not needed for this form. You can download them from a website. They may vary a little bit from state to state. There's one on South Carolina that has some of these forms available. So a lawyer is not required, but in some states, including in South Carolina, you do need a doctor's signature on the form. And it doesn't restrict basic treatment efforts that might be given within accepted medical standards, and it does allow for pain control and comfort care. So our current social climate in terms of dealing with end-of-life care is such that we expect patients to have more ability to be able to engage in that care for themselves, to make decisions, and for family members to be able to communicate those decisions. But the thing is that we don't have those conversations much. This is what I found in teaching this class last semester. We don't have those conversations within our families that much. So we're not familiar with what a family member's wishes may be. And we don't often have someone maybe that's been declared to have health care power of attorney for those decisions. Ultimately, over 90% of Americans, at least in one survey less than 10 years ago, almost 20 years ago, said that they would prefer to die at home if faced with 6 months to live. And any other evidence I've seen suggests that it's at least 75% or more in more recent surveys as well. People would much prefer to be able to die at home than in a hospital. So how to do this in an effective and timely manner is a challenge that we still have to address in the context of the hospital, in the context of doctors' offices, and in the context within our own families. So, Ruth engaged in a number of research projects, and she'll tell you about them.
Well, this is one of the projects that I had done in Hahnemann University Hospital when I was there as the researcher. And I have to confess that I'm kind of I never really deal with end of life other than in the nursery and my own personal experience with family members. So this was all new to me, so it was really very interesting. We had read an article about allowed natural death that was proposed, and it was being used in Texas by Reverend Chuck Myers. And that whole state was going to use this terminology. You want to hear something ironic? Right after he did this, he died in a car accident. So, because I tried to contact him and no go. Okay. So in Grand Rock, Texas, he actually defined the 3 levels of care that patients would receive: full support, including resuscitation, intermediate support, with some interventions decided on by the patient and family. But I'll tell you a personal story later that they had better be written down because, you know, families from the New York area like mine, we were like in the room slugging it out on that one. And comfort and support measures, which would be what allowed natural death would be. Okay, then the American Nurses Association always has to, weigh in on these type of decisions once they're publicized. And they revised their position statement, actually, and they liked it because they thought that the current terminology, do not resuscitate, first of all, there's a lot of myths that go around that terminology. People think that healthcare personnel are not going to be as aggressive with you if you have a do not resuscitate order because they want your organs. You've heard all those. There's a lot of difficulty and confusion around that. It says that the organizational policy, basically nurses must advocate for and play an active role in initiating discussion about allowing natural death with patients, families, and member of the healthcare team. Because at the end, and Karen can help me with this because she works in critical care areas, at the end, after the physician tells the family what's going on, they basically leave because they only have 5 minutes and you're there holding the bag and you have to really explain everything to them. So it's very important for us to advocate for the patient. They thought allow natural death was the better choice because death is actually confronted and the word is used. Which do not resuscitate, if you have a family that's not familiar with all the hospital terminology, they might not realize exactly what the end result of that's going to be. Okay, but here's the clincher. A&D orders must be signed by a physician. So we wanted to figure out a condom what the physicians and what the nurses thought about this. So this is where the research study came in. We are also obligated to include the family in this decision, just let you know, that it should be a shared decision-making process. Not all experts agree in the healthcare field that allowing natural death is the best way to frame end-of-life decisions for patients and families. And can you guess what Chen and Younger are? Physicians. DNR orders can be much clearer and are substantiated by law. Right now in South Carolina, I don't think a physician could write an allow natural death order because what's on the books is DNR orders. So all states have not adapted any kind of different language yet.
So A&D is the same thing as what kind of, practically?
Practically the same thing. If you're not resuscitating somebody, you're not doing anything extraordinary to save their life.
What about giving me morphine?
Always. You should always take care of their comfort and their pain. And that's a whole nother thing that we can do is how much morphine is comfort and how much morphine is real.
Why are you pointing at me?
I think that would be a good study this summer.
Morphine expert.
Anyhow, so yeah, and they should provide comfort at all costs. Other physicians do agree that the goal is truly, like you said, is to provide comfort and pain management. The A&D change in wording is also supported by the World Health Organization, who had to weigh in on this, but then they got more aggressive with it because they want the word aggressive comfort care. Which I think also just confuses things because then you have that kind of word in there that's really, what would you say? Okay, what kind of word is that? Too aggressive. Too aggressive. Right. Okay, so we investigated at, there was a grounded study done by Jones in 2008, and they surveyed people, and what they thought in a pediatric medical unit that allow natural death was ambiguous. Now this is in 2008, so it's getting a little old. There's been other studies since, but this is what we used as a foundation. But then it also increased the family's ease, and it was easier to talk to them about death than using the words "do not resuscitate," and it promoted family healing. So that was a grounded study. Then Veneman did another study that looked at the two terminologies, DNR and allow natural death. So we called this woman up, who was a nurse researcher, and we said, hey, can we use your tool and replicate your study? She said, go for it. I said, because we have a different population here, because we're in Center City, Philadelphia. So we wanted to see how our population worked out to her population. So we replicated the study, ours was basically a convenience sample. This was at home. We had physicians, we had med students, we had nursing, and we had nursing students. So we ran around the hospital with surveys, and we used the vignette that she had used in her study to sample everybody. This is just how the procedure went. We just basically ran around, we had them return studies, they were anonymous studies, surveys, so it wasn't a big deal. But this is what the survey read. A loved one is terminally ill, and physicians have indicated that her death is near. Your loved one has indicated that you have legal power of attorney for her health care. You are being asked by the medical staff to make a decision concerning the institution of cardiopulmonary resuscitation. All other measures to provide comfort and dignity of care and dignity to the person in your care will be continued, and allow natural death order is in place. Would you agree to that?
Yes.
I would too.
Use your clickers.
Use your clicker. Come on, again, go. Can't say that, it's small. Most people would agree to that. Some, they might want more. What?
Those two agree.
They might want more information on what that all means. We used a visual analog scale with the physicians and all the nurses there relating to the question. 87, here, this is really a repeat. 87 nurses or nursing students were surveyed, 100 physicians were surveyed. 78% of the physicians were in the 26 to 40 age range compared to 3% of the nurses. So these were our demographics, which is really getting sad, isn't it? The largest range for nurses were 41 to 60 years old. So we have a lot more experience, so you have to take that into consideration. 47% said they were practicing internal medicine. We just caught them, me and my research group just caught the internal medicine rotation just coming into the hospital. So they were good physicians because they weren't too specialized so that they wouldn't understand this. Of the physicians, 50 were women, 48 were men. 2 said they didn't know. Okay? Sometimes in Philly, people just don't know. It's okay.
I don't want them making my hand decision.
78% of nurses were, of course, female. This was the ethnicity that you find in the city, and this is always, pretty interesting when you look at the physicians and the nurses. There's sometimes quite a disconnect in ethnicity, okay, in medical schools compared to nursing schools, which sometimes interferes with the interprofessional communication process, I do believe. That would be another great study. Okay. And then we figured, you know what, religion is going to play a part in this, because how people view death also has to do with their religion. So this was the religious makeup of people, and there was some, that one was down their religion, but now you can see why I was so clueless when I got to South Carolina. And I had to ask a lot of questions. Okay. 83% of nurses said that they would be 75% or greater likely to give consent for an allowed natural death order. 51 would be 100% ready to give that order. 78% of physicians reported they would be 75% or greater, and only 33% would be 100% likely to give consent. There was no significant difference, because when we did the multiple regression, there was no significant difference between age, religion, ethnicity, or education level. Remember, we had people in there that had 2 years of healthcare education, up to people that were, fellows and physicians that were out for a number of years. I thought that was very interesting. I thought that the older physicians were going to be more opposed. So I don't know if my sample wasn't big enough, or I just hit some people that were progressive thinkers. Okay, and that was just the result of the visual analog scale. Okay, our study did support the study that we replicated. Overall, A&D terminology appears to be acceptable by most professionals. Specific interventions that fall within the order need clarification with any group. The goal of the care should be clearer, and we should start looking at death as a natural life process. And that's the biggest adversity that we have, actually, in our society, that it's a natural process. Since 17% of our gross national product in healthcare is spent in ICU in the last few days of life. We want to save everybody. And in my specific field, we're trying to save itsy-bitsy babies, fetuses. Okay, of course, every study has limitations. Non-random sampling, whatever physicians and nurses we got on the unit, we got, you know. It was a big place, like 18 stories. Many physicians were from internal medicine, so other specialties might have viewed this different. And specialties in the field of nursing weren't well represented. We did not try and get into the locked psych unit to ask them. We did not go to pediatrics and ask those people either. So, and we did not go to maternity and the nursery and NICU and ask those people. So we didn't get those specific specialties. Although I think another good survey would be the NICU people. Changing the way end of life is treated in our culture is going to be a paradigm shift eventually as the new healthcare policies come into play. Changing terminology is really just an initial step. It's only words, but words really do matter in the hospital when you're speaking to patients and to families. There are now over 100 hospitals, hospices, and nursing homes throughout the U.S. that use A&D as terminology. And advocacy groups, even though the guy died in a car accident, are still going on to try and carry his mission forward and get more people to use this terminology.
I wanted to, now, I didn't know about the 17% of the
That's the last that I read, yeah.
at the end of life.
Or spent on the end of life.
Okay.
Wow.
So that's as a percentage of this type of care. So this is over the course of the lifespan in general. Most of the healthcare expenses that we spend are in those last few years before someone dies. And now you're saying that most 17% of that
It's like in the last few days.
is in the last few days, which suggests we do need to have more of a cultural conversation about death as part of a natural life process, rather than just doing everything we can to keep someone alive as long as we can, and then realize now that I've said that that's kind of reflecting my own views on the issue. Obviously, some people are going to want to do that, and I do show my students several videos, one of which shows a man with his mother having healthcare power of attorney, and she is there, she's non-responsive, she's been there for 10 months, and he is visiting her every day. And the story is about that situation in particular, that part of the story is about that. He visits her every day, and what the hospital has done is they have gone to court to basically have not his healthcare power of attorney lifted, but rather to be able to not engage in any resuscitation procedures if she reaches that stage where she is no longer, her heart is no longer beating. So she's on a ventilator, but she's still being kept alive, and he has said very specifically he does not want anything to happen, and he would want the extraordinary measures taken at any point if something were to happen. They went to court to fight that so that she could be allowed to pass if the situation became critical in that case. At the end of that little section that I show the students, it says he's been letting the bills pile up in his office at home, and that it's now cost Medicare over $2 million for her care because she's been in the hospital in that situation for 10 months. And there's other videos I show. There's another one that I show that talks about a doctor and nurse and their sister, the three of them, having to make decisions about whether or not to remove the ventilation tube from their 86-year-old mother's mouth, and making that decision with the doctor giving her care, and how that decision affects all of them, and how they contribute to that decision each individually. And it's definitely a video worth watching if you ever get a chance. It's a frontline documentary, and that's just a portion of this documentary as a whole in terms of the decisions that we make and the decisions that we know people have to make in the hospital. So I recommend it if you get a chance to watch it.
I just have one more comment, if you mind. I wrote this up, in holistic nursing practice. I don't know what's holistic about dying, but anyhow, they took the article, and then the New York Times called us at Hahnemann, and we got quoted in the New York Times for this article. So this was probably one of the most non-rigorous research studies I did there, and it hit the big time. So you never know. So disseminate